Welcome to the CCBI bioethics webinar, MAiD for Mental Illness, Exploration of Deeper Issues with Sephora Tang and Dr. Patricia Murphy. My name is Eoin Connolly. I'm the Executive Director of the CCBI of the Canadian Catholic Bioethics Institute. We're very excited and grateful to have Dr. Sephora Tang as our speaker today. We're very also happy to have everyone else on the call with us. We've had over close to 600 registrations for this evening. I guess maybe earlier in the day for some people on the West Coast, but evening out here in Toronto. And we're going to give it a few minutes before we start, just to allow people the opportunity to get on, get home, get settled, maybe get a little bit of dinner, and we'll get started. So apologies for any delay. Maybe we'll wait one more minute, and then we'll get started.
I see in the chat it says somebody says they have no audio.
I'm hearing everyone okay on my side. If that individual could maybe just check their audio, make sure their audio is turned on and the volume turned up.
And I won't be monitoring the chat once I get started.
Yeah. It sounds like audio is working for everyone else for the most part, from what I'm seeing. Okay, I think we're starting to get up to a good number now. And maybe we will get started. Before I get into introductions, just a few little housekeeping items, if that's okay with everyone. So this webinar will be recorded and posted for later viewing on the CCBI website. Just to note that the question and answer portion of the talk won't be recorded. If you would prefer a translated version, a text translated version, if you bring your little cursor down to captions and click on captions under, sometimes people have it hidden in settings, but otherwise captions should be at the bottom there for you. And then you can select which language you would like it translated into. Just to give you a bit of overview of our time together, we will begin with Dr. Tang's talk, followed by short reflections by CCBI Program Director, Dr. Patricia Murphy, and then we'll open the floor to questions. Questions can be submitted using the Q&A function at the bottom of your screen. As I mentioned, close to 600 registered for today. So there may be a lot of questions in the Q&A submitted. We'll do our best as best we can to get to as many as we can. If there are any follow-up questions that we don't get to, feel free to email either myself or Dr. Murphy. We'll share our email addresses at the end of the session. Now, without any further delay, it's my pleasure to introduce Dr. Sephora Tang. Dr. Tang is a psychiatrist in outpatient mental health services at the Ottawa Hospital. She is an assistant professor in the Department of Psychiatry at the University of Ottawa and is currently the program director of the Psychiatry Residency Training Program. She's a strong advocate, I would say a strong advocate, very strong advocate, for access to quality medical and mental health care for vulnerable and marginalized individuals, and has appeared as an expert witness before the Canadian Senate and the Ontario Provincial Parliament. She currently serves as a council member of the Ontario Psychiatric Association, a senior health fellow with Cardis, and she is a clinician investigator in the neuroscience program at the Ottawa Hospital Research Institute. Welcome, Dr. Tang. Thank you again, and the floor is yours.
Thank you so much, Owen, for that introduction, and thank you to the CCBI for hosting this talk. Just a disclosure that the views that I present tonight are my own and do not reflect any of the institutions with whom I am affiliated. And so tonight our topic is on medical assistance in dying, talking particularly about the issues relating to applying this for mental illness and exploring some of the deeper issues. So in our time together, I hope to be able to provide an outline of how medical assistance in dying, the term that's used in Canada, has evolved over time, and then outlining some of the key questions and serious clinical and ethical challenges raised by the proposal of extending medical assistance in dying to people with solely a mental illness, sharing a few case examples in the world today, and at the end, I hope to close with some reflections on how this affects families, communities, and what we can actually do, just a few ideas to help support people who are suffering. And so just to clarify the terminology, in Canada, medical assistance in dying, or MAiD, refers to both voluntary euthanasia and assisted suicide. So voluntary euthanasia is where a person gives their consent for a health practitioner to, for example, insert the lethal injection to end their life. And assisted suicide is where a practitioner may prescribe something lethal for the individual to ingest of their own accord. And so both of these methods are legal in Canada. Since 2021, when Bill C7 came through Parliament, medical assistance in dying, or MAiD, is actually a misnomer, because with that bill, you no longer need to be at the end of life or dying in order to access euthanasia or assisted suicide. So really, it should be termed a medically assisted death now. And so this is the timeline. Way back in 1972, prior to that, suicide was actually a criminal act. But then Canada decided to decriminalize it in 1972. That was probably due to the recognition that people who are trying to commit suicide probably need help and not jail time. There's the famous Rodriguez case with the Supreme Court of Canada in 1993 that some of you may remember. And this was when this prohibition on an assisted suicide was challenged. And at that time, the court favored more heavily the societal values and what allowing this could mean for the fabric of society and the protection of the vulnerable, which had a heavier weighting compared to the individual freedoms. As we move forward in time from left to right, we see that in Parliament, it's often defeated. And it really wasn't until 2015 with the Carter case that this became a landslide change in Canada. Quebec was actually ahead. They issued a Bill 52, and within their province, they encapsulated this within healthcare, which is regulated provincially, and so they were able to sneak in. Well, it wasn't called medically assisted death at that time yet, but euthanasia and assisted suicide as part of end of life care. And then in 2015, the Carter case struck down the criminal prohibition against assisted suicide in the criminal code. And there was a greater emphasis on individual freedoms at that time over societal values. And then in 2016, that was when Parliament came out with their first bill, C14, that outlined the limitations around how a medically assisted death could be provided. And they very deliberately chose to limit it to end of life. And they felt at that time that would strike a balance between allowing people to die with assistance while safeguarding others. And at that time, likely people suffering solely from a mental illness would not have been included by virtue of the fact that having a mental disorder is not life-threatening, generally speaking. And then came the Truchon Gladue case in 2019 that struck down the prohibition for people who were not reasonably foreseeable death. And so that meant that anybody above the age of 18 who were adults, according to the criteria, who were suffering intolerably with an incurable illness would be able to access a medically assisted death. Back then in 2021, the government gave a 2-year sunset clause that prevented this from being extended to those with a sole mental illness as the underlying medical condition. And they gave us 2 years to kind of figure out how we're going to apply that. And then 2023 came along when it was supposed to be enacted. The government decided to delay it to 2024 because they felt that they weren't ready. And now it's been delayed again for 3 years until March 17, 2027. And as we move from left to right, we see a progression from initially trying to escape from a painful death to then escaping from a painful life. And so medically assisted death for sole mental illness is not legal yet, but if nothing changes by March 2027, whatever legislation we have in place would then be automatically applied to those suffering solely from a mental illness. So going back to Bill C7, this was the second iteration, and what you see in orange are the original safeguards that were in Bill C14 that were deemed necessary at the time, and then in 2021 they said that, well, this is no longer necessary. And so the most important change here was they struck out the requirement that the natural death has to be reasonably foreseeable. They also got rid of the 10-day reflection period for those who are termed have to have a reasonably foreseeable death. And you also no longer need to express consent immediately before provision, which was previously deemed very important to get that final consent. But now people can write a waiver, and as long as that's signed at a time when they were still capable of making that decision and they had an agreement with the MAiD provider, their life could be ended even if they weren't able to express consent immediately before the procedure was administered. And then because the reasonably foreseeable death was removed, we now have 2 tracks, one where death is reasonably foreseeable, and track 2, which refers to those who are no longer reasonably foreseeable. They did require for track 2, where death is not reasonably foreseeable, that there's a 90-day assessment period, but that could also be shortened if the patient risks losing capacity to consent. You also only need to have one witness. It can be a healthcare worker that is the witness, so there's no longer an independent witness. And it requires a consult with an expert in the condition that's causing the suffering if neither assessor has expertise. But as I'll explain a little bit later, there's some problems with what it means to consult with an expert. And the patient needs to have been informed of all means available to relieve their suffering, and that they have seriously considered such options. But we know that simply being informed of an intervention is not quite the same as being able to experience the suffering being relieved from a potentially suitable treatment. And so with Bill C7, the government was mandated to put together an expert panel to review guidelines, protocols, and safeguards for the implementation of medical assistance in dying for solely MD-SUMC. So that stands for mental disorders as the sole underlying medical condition. They came out with their report, this expert panel, in 2022 and concluded that it was unnecessary to develop separate legislation for mental disorders because they reasoned that people with mental disorders and another medical condition that allowed them to access medically assisted death was already legal. And so what should happen is that they should provide a framework that would cover all of these complex issues. However, in my opinion, I believe that the conclusions that there was no need to develop separate legislation, and the guidelines that were issued by the expert panel are insufficient, and leaves serious questions about the accountability and the oversight of now expanding this further to people with only a mental disorder as an underlying medical condition. There were two expert panel members who resigned during the process because they felt that the process was not rigorous enough. And part of the issue is trying to define the eligibility criteria. And the expert panel actually said that it is not possible to give a specific number of treatments a person must have tried that will apply to all medical conditions leading to a MAiD request. And I think that highlights the difficulty of being able to ascertain when a person is actually eligible or not. And that is one of the areas of concern amongst many medical professionals that are facing this now. So they put together a panel, and they came up with the Health Canada Model Practice Standards. So this was developed in order to standardize the practice of MAiD across Canada. And I think they were hoping that the provincial regulatory colleges would adopt these as a framework for their province to ensure some consistency across Canada. And the purpose of these standards were to provide a greater understanding of eligibility criteria, to help us understand some of the nuances, but again, it's not enough. And some of the procedural safeguards that are required and the reporting requirements. And it also sets out the minimum expectations for healthcare professionals involved in the practice of medically assisted death, and also outlining specific legal requirements for MAiD assessors and providers. However, despite these efforts, there still remains significant unresolved issues, including clarity on eligibility criteria, which I will expand upon, the assessment process itself, and considerations relating to the practitioners themselves. So, in greater detail, according to the eligibility criteria, within the law and the legislation, eligibility criteria involves terms like incurable, irreversible, and intolerable suffering. In mental health, many of the conditions that we treat are incurable, they're chronic. However, with the recovery model, we try to provide interventions to allow the person to live a meaningful life and to alleviate their suffering to the point where they are not having suicidal ideations, but there is ability to support people who have mental illnesses, despite the fact that their condition is technically incurable. Secondly, there is no consensus on how to establish irremediability in mental disorders. This is a fundamental difference, I believe, in comparing the application of legislation to mental disorders and other disorders or illnesses where it may have led to death, or there is a clear progression that is consistent over time. But with mental illnesses, there is a plethora of different treatments that can be done. There are factors that are not related to medicine that can impact on a person's suffering, perception of pain and suffering, for example. And so it's really difficult to say that any one person is not going to be able to get better. And so that risks prematurely ending the lives of people who could have gone on to live for decades earlier than warranted, and the underlying condition would not have led to their death. There's also no requirement to undergo available evidence-based treatments prior to eligibility. What I mean by that is that patients can decline treatments that they feel are unreasonable. This decision to forego treatment can be subjective. The assessor does need to agree also, but that determination is also subjective. So there's a problem there where a patient who could be suicidal may not want to undergo treatment. And then depending on what kind of assessor you have, whether they have a very high threshold or a low threshold, It could be that that provider will then agree with the patient's suicidal wishes and provide MAiD, despite the fact that maybe a different provider would have had a higher threshold and felt like that was an inappropriate request. So there's not a lot of oversight about that. MAiD may be provided in contexts where suffering is driven by structural vulnerabilities. So, for example, poverty, lack of access to care, these are real concerns, especially in people with mental disorders who often are more vulnerable to these structural inequalities. And we do know that when a person is homeless, when they're struggling with financial limitations, that can lead to worsening mental health and often suicidal thoughts. There's also no clear framework to distinguish MAiD from suicidality, and this is especially true for chronic suicidality. So the Health Canada Model Practice Standards briefly mentions acute suicidality and says that you should not be providing medically assisted death to those who are in an acute state of suicidal ideations, but this does not address those who suffer chronically from suicidal ideations that can wax and wane. And previously, we would have provided suicide prevention techniques to people with chronic suicidal ideations and to support them through that process, rather than deciding when would be an appropriate time to end that person's life. So with all of these things, it's really difficult to have criteria that would determine eligibility in a manner that's consistent, reliable, and clinically valid. Secondly, the assessment process, there's serious concerns about that as well. So currently, despite the federal panel requiring or recommending that a psychiatrist specialist be involved, after that guideline was reviewed or the standards were reviewed provincially, they actually struck out that requirement requiring a psychiatrist to be involved in that assessment for people who are requesting medically assisted death solely due to a mental disorder. Secondly, the expert consultation does not actually require direct patient assessment. So if a MAiD provider consults with a psychiatrist, for example, that would be deemed sufficient. The psychiatrist doesn't actually need to see the patient directly. And so that is likely not a good idea. Many things can be missed when you don't see a patient directly. And 2 assessors are required, but this does not limit doctor shopping. So if a patient receives a negative from a psychiatrist or a physician who is doing the assessment or a nurse practitioner, and the patient doesn't agree that with the assessment that they are not eligible, they can shop around for another assessor who may be more inclined to agree with them. And we've seen in cases recently where somebody was denied a medically assisted death in one province, traveled to another one, and was granted it. And also of concern is that clinicians are encouraged to initiate the discussion about having a medically assisted death if it's felt that it's in alignment with that patient's values. It's difficult to know what those values would be if you didn't initiate the conversation. But I think what is concerning here is that when a health practitioner actually suggests, well, have you thought about a medically assisted death, that can be perceived as an inducement to ending their life. So that could be problematic, especially if you're talking to people who are already suicidal at baseline. And finally, there are practitioner concerns as well. So just from a practical perspective, many psychiatrists and physicians try to prevent suicide. And so how do you differentiate between facilitating a suicide and preventing a suicide? So it there creates an ethical tension fundamentally. And conscientious objectors are required to provide an effective referral, even where objections are grounded in clinical judgment. So they actually clarify that you could be against a medically assisted death for this reason, but if you're against it for example, providing a medically assisted death for somebody who is living in poverty and they want to escape their poverty, and that's the underlying reason. If you disagree that that would be a reasonable reason to have somebody's life ended, granted if they have all the other criteria as well, they're still expected to provide an effective referral. And even if they feel that clinically this is not up to standards, so for example, if they declined a certain treatment, for example, they may need to provide an effective referral if they disagree. And so this can contribute to moral distress and undermine the professional standards of care in practitioners. So it leads to the question, if the legal threshold for eligibility is largely subjective, based on terms that's hard to define, that's influenced by the patient's and assessor's biases, and also contrary to usual standards of medical care, due to the allowance of the refusal of treatment, should meeting legal eligibility criteria be the only factor considered in granting access to medical assistance in dying? And just to highlight some cases that were in the news in the last few years, this is not pertaining to a mental illness directly, but just wanting to highlight that cases like this have already existed, where the underlying reason for the medical assistance in death, or like the reason why they requested it, was because they failed to get adequate help, adequate home care. So Sean Taggart was 41, Sathya Kovac was 44. They both had amyotrophic lateral sclerosis, a neurodegenerative disorder, but they couldn't get the home care that they required. This is the case of Sophia, who was 51 when she died from MAiD, and she had multiple chemical sensitivities. She wasn't able to find housing that would provide her with the clean air that she would require to be able to live comfortably, and so she opted to die by MAiD as well. Rosina Camus was 41. She's a former university statistics teacher, and she actually documented her road to medical assistance in dying, and she wanted her friends to keep it a secret that the underlying reason why she was asking for medically assisted death was because of poverty and isolation. Her story is very well documented in an Al Jazeera documentary that I would encourage you to read. Or to watch. But she said, I think if more people cared about me, I might be able to handle the suffering caused by my physical illnesses alone. Sometimes all the pain will go away just by having another human being here. Her quote here highlights the devastating impact that loneliness and isolation can have. And we know about her story because she had documented it very well with recordings. But how many others are like Rosina that we will never hear about because people who are dead aren't able to tell their stories? These cases have led to headlines in Canada like, why is Canada euthanizing the poor? And how poverty, not pain, is driving Canadians with disabilities to consider medically assisted death. So the concern is, if cases like these are already happening prior to another expansion, what's going to happen next? Dr. Simon Hatcher is the chair of the Department of Psychiatry at the University of Ottawa, where I work, and he wrote a brief to the Special Joint Committee between the Senate and parliamentarians studying this issue. And I just want to read the quote in orange. He's talking about how social determinants of health have an impact on people's mental health and those who are chronically underserved. For example, the homeless often suffer from mental disorders, and they're disproportionately affected by these impoverished living conditions. And he said, it's therefore of concern that the panel suggests that patient eligibility for a medical assistance in dying can be approved despite treatments being inaccessible. A medical intervention that causes death is not a substitute for proper medical treatment, and financial poverty is not justification for death as a solution. He highlights the fact that many psychological treatments are not covered by publicly funded healthcare, such as psychotherapy, and some of the newer treatments like ketamine, for example, are not covered, and people have difficulty accessing a treatment that could be life-saving. So more specifically for mental illness as a criteria for euthanasia and assisted suicide, I just want you to consider some of these facts, that 1 in 5 Canadians suffer from a mental illness in any given year, and that suicidal thoughts is one of the many manifestations of mental illness, is baked into some of the diagnostic criteria. A medically assisted death for mental disorders undermines efforts to provide appropriate psychiatric care, which can often take a lengthy time, which is not afforded by the current legislation. And then the question about suicide facilitation versus suicide prevention. So normally in suicide prevention, we restrict access to lethal means. That's one of the methods of protecting people. However, a medically assisted death does exactly the opposite by providing a foolproof way for people to die when they request it. And finally, we talked about the difficulty in predicting irremediability in mental disorders. It's not as easy to do that compared to some other conditions. And just to also provide some context, in a study done in 2024 by CAMH, this was on students and the mental health of students and how they're suffering. So 19% of students report harming themselves on purpose, and 18% had serious thoughts about suicide in the past year. Remember that the legislation is applicable to people who are 18 years and older. So this is the generation of youth who we are ushering in to this new era where they may be able to access a medically assisted death once they turn 18. So we talked about the difficulty in predicting irremediability in mental illness, and there's no consensus amongst medical professionals. And the difficulty here is that we could be putting somebody to a premature death who would have been able to get better. And contrast this with the reason why Canada abolished the death penalty, because at that time they felt that one wrongful death was deemed to be too high a price to pay. And I wonder how many people have actually died in the MAiD regime where their eligibility would have been questionable, and how high a price are we willing to pay to prematurely put somebody's life to death. In 2021, Dr. Sonu Gand and I wrote an op-ed that was published in the Hamilton Spectator, and we said that public health policy that risks providing death to suicidal people who could otherwise have recovered should be based on available evidence and standards, not arbitrarily on individual value judgments of assessors, which is what seems to be happening these days. And so the issue about the treatment refusal, people who decline treatment are still eligible to receive a medically assisted death. And originally, this would have been for things like somebody has cancer, they didn't want to undergo chemo, which is totally legitimate. At the end of the day, the cancer would have likely ended that person's life. But in a mental disorder, not undergoing a treatment is not necessarily going to lead to their death, but providing a medically assisted death would. And patients have been able to access a medically assisted death even without having undergone a treatment refusal. That's not having undergone treatment. So that's part of the legislation. Compared to other jurisdictions where mental disorders is eligible, they require much stricter guidelines where both the patient and the physician must agree that there is no reasonable alternatives in regards to treatment, that really this is last resort. And in Belgium, they even require 2 independent psychiatric consultants to provide an opinion. And we know from Health Canada reports that the deaths that are happening now, very few percentage of the time, psychiatrists are being consulted. And then as we saw with the Health Canada model practice standards, even for a mental disorder, they are not required to have a psychiatrist do that assessment for eligibility. So a few other things in mental health. It requires a lot of hard work sometimes to bring a patient out of the depths of despair. And so it's a lot easier to acquiesce to request for an assisted death rather than persevere and do the hard work to try to bring them out of that dark pit. This is especially difficult when treatment resources are scarce and there are long wait times. Secondly, in mental health, we talk about transference and countertransference. So transference is how the therapist makes the patient feel, and countertransference is how the patient makes the therapist feel. So sometimes the therapist can feel the despair, the hopelessness that the patient is experiencing. And there's a real risk that the healthcare practitioner may provide medical assistance in dying due to their own hopelessness that they feel. And so they feel that, oh, well, if I provide this intervention, I would be taking the patient out of their suffering. But really, is it their own sense of hopelessness that they are acting on as well? And the distinction between suicide and MAiD. So we talked about that, but the former Justice Minister Lametti said that medical assistance in dying is a species of suicide, and suicide in and of itself is not against the law. So if MAiD is suicide, then medical assistance in dying for mental disorders as a sole underlying medical condition blurs the boundary between assisted dying and suicide. Whereas traditionally psychiatry prioritized suicide prevention by restricting lethal means, and MAiD does the opposite. Some stats from the Netherlands, I'm just going to highlight that. So this was a study done by Dr. Kim in 2016 on the types of patients that received euthanasia and assisted suicide who suffered from a psychiatric disorder. And 56% mentioned things like social isolation and loneliness as a cause of suffering. And 52% also had a personality disorder. 35% had depression, including depression with psychotic features. So that brings to question, like, how capable were these patients to make that decision? But going back to personality disorders, my concern here is for people who have borderline personality disorder, where part of the diagnostic criteria is recurrent suicidal behaviors. And previously, borderline personality disorder was thought to be a chronic condition, but there's new evidence that with appropriate treatment, patients with personality disorders can get better with therapy. For borderline personality, dialectical behavioral therapy, which was developed by Dr. Marsha Linehan, is considered the gold standard, but it's very difficult to be able to access DBT. Marsha Linehan said here, the desire to commit suicide, however, has at its base a belief that life cannot or will not improve. Although that may be the case in some instances, it is not true in all instances. Death, however, rules out hope in all instances. We do not have any data indicating that people who are dead lead better lives. And Dr. Linehan herself, we believe, likely suffered from borderline personality disorder, and that was how she got out of her own hell and developed this treatment to help others who suffered. And she came out with her story many years ago. So in regards to structural vulnerabilities, I led a national survey as part of the Ontario Psychiatric Association. I'm one of the general members of council, and we surveyed psychiatrists across Canada. We had 505 responses, which represents about 10% of psychiatrists and psychiatry residents in Canada. And some of the results indicated that the majority of respondents did not support the implementation of MAiD for mental disorders under the current framework. And 80.8% indicated that the Canadian medical system is not prepared for a safe delivery. I know from the numbers that even those who were supportive of expanding medical assistance in dying for solely mental disorders did not agree that the Canadian system is currently ready. In the qualitative analysis, respondents identified concerns around eligibility criteria, the assessment process, ethical implications, and health system capacity, given that very few psychiatrists were willing to actually engage in the process of medically assisted death. And then there were some questions that asked some pointed questions about eligibility relating to structural vulnerabilities. So one of the questions was, if a patient is unable to access standard treatments, would you find them eligible for MAiD? 80.4% strongly disagreed that they would. This contrasts with the fact that within the legislation, they could be found eligible. And then another question was, suppose a person's underlying mental disorder has led to circumstances that are indirect contributors to a person's intolerable suffering, such as negative symptoms of schizophrenia, making it difficult to maintain employment and be stably housed, and having food insecurity. And then the stress from this person's social situation has led to a subjective state of intolerable suffering. Should this person's situation meet the federal legislation's intolerable suffering criteria for MAiD eligibility? 69.5% strongly disagreed, which means that there's a certain percentage that does agree. And remember that you only need to have 2 assessors who agree that this person is eligible to be able to receive it, despite the fact that the majority disagree that person should have been eligible. And so We also asked questions about the assessment process, and recall how I said you don't need to actually have a psychiatrist involved directly in that assessment process. And most of the survey respondents disagreed with that lack of oversight. And so the highlights resolve the gap between federal legislation and clinical practice, where many scenarios that are currently permitted under the law are not considered appropriate by the majority of psychiatrists who responded to this survey. And finally, the impact on families. Many family members find out that their loved one had died by MAiD after the fact. They weren't able to intervene, and so many families are being impacted like this. This, I would think, would be even more of a shock for somebody who didn't have a terminal condition and maybe tried to go to the hospital for help for a mental health condition, only to learn later that they had availed themselves of a medically assisted death. These are the names of some people who had died by MAiD. Donna Duncan, Keanu Vafayan, who's only 26. This happened very recently, just in December 2025. Where he had diabetes and was blind in one eye and had some neuropathy from the diabetes. And John Patrick Tyler Lyon, who is age 77. Their family members have all spoken out about their deaths and queried whether appropriate care had been provided. And they also all had concerns that these individuals very likely had mental health conditions that were not adequately addressed, that was likely fueling their requests. And the impact on the families left behind has been quite traumatic. And you can read about their stories in their own words when they tell it. And so all of these concerns have actually led to provinces to restrict what is actually provided within federal legislation. So Quebec commissioned a study in 2021, and they actually recommended against providing a medically assisted death for mental illness because of lack of consensus, the issue about irremediability, and also, importantly, they felt that allowing this would also change societal views on suicide. And so that would really change the culture in which we live. And they also recognized the lack of access to mental health care, which is likely not an issue just in Quebec, but across Canada as well, where the ability to access mental health resources often exceed the 90-day waiting assessment, the waiting period that's required for Track 2. And most recently in Alberta, they tabled the Safeguards for Last Resort Termination of Life Act, Bill 18, which would effectively restrict MAiD to only Track 1, and defines reasonably foreseeable death as within 12 months. So that's much clearer than what the current legislation requires, which doesn't have a time limit. And they would also explicitly exclude MAiD for mental illness. And so because healthcare is provincially regulated, these provinces have decided to try to take things into their own hands and put more restrictions in place. Back in 2021, I co-authored an op-ed with Dylan McGinty, who's a lawyer, and we said that if we as a society do not invest and advocate for life-affirming healthcare services and social supports to provide dignified living to all, we may one day come calling for help and find the only accessible option offered is death. So we are already seeing these words coming true. And I just want to encourage people to remember that we need to be building a society that is life-affirming if we wish to be able to access appropriate care for us, our loved ones. And so I recognize that these conversations can be rather depressing. So I wanted to end on a more hopeful and inspiring note to end the evening by talking about some stories building hope. And this brings to mind, what can we each do individually to help build a better society where people are provided the supports that they need? And as we heard from some people who had availed themselves of a medically assisted death, sometimes it's just the presence of another person that can help. And that's something that we can all do by giving of our time. I wanted to highlight some stories from Fredericton, where I actually grew up. I'm very proud to be call myself a Frederictonian because of some of the good news stories that are coming out of that little city. But this man here, this man here at the top right, his name is Marcel Lebrun, and so he made a lot of money in software development, sold his business, and then developed this little mini home community, which is amazing. It provides support to people, developmental support, helps them to find employment, and they recognize the importance of living in community. And so they're close enough together that the people who live in this area are able to develop relationships with other people and to, address that isolation that often drives people to want to end their lives. And you don't have to be a millionaire, but this is another good news story in Fredericton where volunteers come together every Monday to bake bread for the food bank. And so we do know that food scarcity is very stressful for people. And if you're not able to eat, then that can lead some people to want to end their lives. So these community members have decided to do something about that. It's a very small thing, but I think it's a way of building community with each other as well, and also helping others in need. And finally, I wanted to highlight this charity, Lion Hearts Incorporated. And what they do is take food that would have been wasted at large stores like Costco or other bakeries, and they collect all of that and redistribute it to homeless shelters or people who provide food to those who don't have what they need. And so this has reduced a lot of food wastage, and they also provide other services to help people who are impoverished. And so these are causes that are well worth supporting. And finally, I just wanted to end with this quote from psychiatrist Dr. David Viscott, that the purpose of life is to discover your gift, the work of life is to develop it, and the meaning of life is to give your gift away. So everybody's life is a gift. Your life is a gift to others. And I think as a part of some concluding remarks to this presentation is how we can value each other, value the gifts that we have to give just by our presence. A kind word, a listening ear, sometimes can make a significant difference in a person's life. I have so many patients who are living very isolated lives because of difficulty integrating into the community. And you just never know what a kind word, a random act of kindness can do for somebody else who's living in despair. It could literally mean the difference between life and death for some people. And so that sense of building community, seeing the people around you, and recognizing that sometimes people suffer in silence. Your neighbor might be struggling with mental health, and you may not know, they may not let you know. So I think it's just developing an awareness that there are a lot of people who are suffering silently. I have serious concerns about where the legislation is heading if it's expanded to mental disorders as a sole underlying condition in less than 1 year now. Because I see the structural vulnerabilities, the impoverishment that many of my patients struggle from. And it's difficult to find the help already. It's difficult to find mental health resources, psychiatric care, just to provide the basic psychiatric care, let alone having such detailed assessments to ensure that this legislation, if it goes forward, is targeting those who meet the eligibility criteria. But again, that's really hard to even know what that means. So I hope this talk has provided you a little bit of insight into our world in mental health, and also to raise some serious concerns that you can think about. And if you're able to talk to your member of parliament to express concerns, I know the MAiD committee, which is the special committee composed of members of parliament and the Senate, are now restudying the expansion to MAiD for mental disorders. And they are looking at that issue again right now before the 2027 expansion. So my last slide is just a few mental health resources. Dialectical behavioral therapy, that's a free resource that you have, as well as the Connolly Behavioral Therapy Center for Clinical Interventions. I recommend that everybody access these. They're very good to help you maintain your own mental health, and they could be a resource to somebody that you can help as well. and also the suicide crisis helpline. And of course, sometimes talks like this can be very triggering for some people, so do know that help is available, and in case of emergency, there's the 911 emergency number. And I will end there and turn it back to Eoin.
Thank you, Dr. Tang. That was very, very informative. Thank you very much. I'll now invite Dr. Murphy to share a few short reflections from a Catholic perspective, and then we'll move on to the Q&A section of the presentation. So Dr. Murphy, over to you.
Thank you, Eoin, and thank you, Dr. Tang. Thank you for your deep, thoughtful, honest, and very sensitive analysis of clinical and ethical challenges raised by the proposal to extend MAiD to people with mental illness. You have given us so much to think about, and we're extra grateful given how busy we know you are, and that yet you made time for this webinar. As we've heard tonight, there are very real and universal human concerns about extending MAiD for mental illness. You don't need to be Catholic or a person of any religious faith to find the MAiD for mental health proposal deeply troubling. We've had such an overwhelming response to this presentation tonight, and that tells us that this is a timely and necessary conversation. It touches the lives of all Canadians. Tonight's presentation came about because the mission of a Catholic Bioethics Institute like the CCBI involves engaging the works of experts, such as Dr. Tang, and the wisdom of other disciplines. As Catholics often say, faith and reason work together. In February, the Permanent Council of the Canadian Conference of Catholic Bishops issued a statement of strong support for Bill C-218, a private member's bill that would prevent MAiD for mental illness. This letter recalled the Canadian bishops' strong opposition to euthanasia and assisted suicide, MAiD, for any reason. It also repeated the call for authentic, accessible palliative care and better supports for persons living with mental illness. To quote that letter, as long as Canadian legislation regrettably continues to permit euthanasia, the CCCB will also advocate for measures that prevent even wider and more vulnerable segments of the population from gaining access to it. Pope Francis repeatedly urged us to protect the most vulnerable among us, to resist what he called a throwaway culture. The message is clear. We say no to MAiD, but we say yes to better supports for all vulnerable Canadians, including those living with mental illness. And we say yes to the inherent and unconditional dignity of every single member of the human family. As the Catechism of the Catholic Church says, the dignity of the human person is rooted in his creation in the image and likeness of God, and it is fulfilled in his vocation to divine beatitude. God is a communion of life-giving persons, and made in his image, we are created also to be in life-giving communion with God and with others for all eternity. This stunning vocation is the basis of our dignity. We are relational by nature. Each of us is made to give and receive love. And Dr. Tang spoke beautifully about that. And nothing, including frailty, illness, whether physical or mental, or loss of control, can change this or diminish our worth and dignity. St. Pope John Paul II wrote that we discover the connectedness and value of people through their interdependence. It is reciprocal. Sometimes we're the caregivers, and sometimes we need to be cared for. Everyone has a unique and essential role to play. As Pope Leo said in a message to the 2025 ALS Walk for Life, the quality of human life is not dependent on achievements. The quality of our lives is dependent on love. Years ago, a student said something that I think is one of the most beautiful things you can say to someone. especially if they're not well physically or mentally and may be tempted to despair. You are worth wasting time with. How can we help those who are suffering deeply to see that their lives still have meaning and purpose? And again, Dr. Tang gave us some beautiful, hopeful suggestions at the end. In this Easter season, especially, when Christians celebrate the resurrection of Christ, his transforming love, and the promise of new life, we are reminded that we are not alone and that despair need not be the final word. This is a season of new beginnings and new reasons for hope. Hope for those who are ill and for those who accompany and support them. Finally, I would like to mention also, and again, the Help Not Harm campaign. It is an initiative of the Archdiocese of Toronto, and it has spread far across the country. Importantly, it also lays out reasoned arguments against the expansion of MAiD for mental illness. And it invites Canadians to write to their MP and ask them to support Bill C-218, that bill that would prevent MAiD when mental illness is the sole underlying condition. And to learn more about this, you can go online and visit helpnotharm.ca. Okay, over to you, Eoin.
Thanks, Dr. Murphy. That was excellent. We have a lot of questions coming in through the Q&A function, and we'll try and get to as many as we can. I know we started a few minutes late, and we'll take. I don't think we're going to get to all of them, unfortunately, but hopefully we can get to some of them. So thank you both, Dr. Tang and Dr. Murphy.